So welcome everyone. Thank you all for joining today's event titled Strengthening Syphilis Care in Indian Country. This event is the first of two events in our Standing Together to Address Urban Indian STI Disparities Community of Learning series. I am your host, Maddie Curry. I'm a public health program manager at the National Council of Urban Indian Health, which we also refer to as NCUIH. And today you will also be hearing from our guest speaker, Jessica Leston, who is the director of the National Center for Clinical Support and Preventative Health Services at the Northwest Portland Area Indian Health Board. Next slide, Rachel. Thank you. So today's session will be recorded for educational and quality improvement purposes. We ask that you please turn on your video to help us engage with you and to mute your microphone when you're not speaking. And we also ask that you please enter your name, organization, and tribal affiliations if you have any in the chat so we can get to know you. Next slide. Great. So during today's event, after this introduction and overview, we will move into our knowledge sharing, which is presented by our subject matter expert, Jessica Leston. Then we will open the floor for questions before closing today's event. Our objectives for this session include to improve UIO's knowledge of syphilis disparities that affect American Indians and Alaska Natives with a focus on urban Indian populations, to enhance understanding of syphilis pathology and epidemiology among UIO clinicians, and to provide an overview of how the CDC's recommendations for providing quality STD clinical services 2020 apply to syphilis care at UIOs. And finally, to increase UIO's awareness of culturally relevant syphilis resources. We also have a survey that you can take to share your feedback on today's event, and this survey can be accessed by scanning the QR code that you'll see on many of today's slides or via the link that we just shared in the chat. Next slide. So the National Council of Urban Indian Health, also known as NCUIH, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V Urban Indian Organizations, or UIOs, under the Indian Health Service and the Indian Healthcare Improvement Act. NCUIH strives to improve the health of over 70% of the AIAM population that lives in urban areas, supported by quality healthcare centers. Next slide. We would also like to acknowledge that the NCUIH is proud to partner with the CDC as supported through our cooperative agreement. The CDC is an agency within the Department of Health and Human Services, and the contents of this program don't necessarily represent the policies of the CDC or HHS and should not be considered endorsement by the federal government. All right, next slide. Great, so now we'll move into our knowledge sharing portion of today's event. So I'll just introduce our guest speaker, subject matter expert. We are honored to have Jessica Leston sharing her knowledge with us today. Jessica is the director of the National Center for Clinical Support and Preventative Health Programs at the Northwest Portland Area Indian Health Board. Her work focuses on systems and policy change, increasing clinical education and connection for clinicians and public health professionals for IHS, tribal and urban Indian health programs and clinics, understanding data trends and projections for American Indian and Alaska Native people, and building health education for tribal communities. She began her public health career working at the Alaska Native Tribal Health Consortium in 2004 and has worked in tribal health ever since. She strongly believes in learning from traditional Indigenous ways of knowing to help guide, direct, and in traditional Indigenous ways of knowing to help guide, direct, and strengthen our public health systems. In her life and work, she honors the Alutiiq cultural value: we are responsible for each other and ourselves. Now I will hand the floor over to Jessica for her presentation. Oh, Jessica, you're on mute. Sorry. Thank you.
Thank you so much, Maddie. I appreciate the kind introduction. And also thanks for NCUIH for asking me to talk a little bit today on probably, well, definitely my favorite STD, syphilis. And I will, it's old sometimes, share my screen and we can get started. Okay, all set?
Looks great.
Okay, great, finally. Amasa, Jessica, DYU. Hi, everybody. My name is Jessica. I use she, her pronouns. My mother's side of the family came to Turtle Island as settlers from Germany, Ireland, and Sweden. And my father's side of the family came to Turtle Island from Austria, Finland, and also from Southeast Alaska, being Simpson, originally from British Columbia. I have worked at the health board now for about 13 years, 12 years, and then I worked in Alaska for 7 or 8 years. So almost combined 20 years of experience that I absolutely love. It's so nice when you can do work that is meaningful and you can see a positive impact over 20 years. You can see needles slowly start to move. So I'm really happy to be here and enjoying the space with you today. So like STIs are not a thing that we're talking about like right now in this space and time only. Like there have been increases in STIs for a long time. There have been outbreaks of STIs, gonorrhea, syphilis, HIV in Indian country, you know, over the 20 years that I've been working with them. It's just currently with syphilis, there's a clear association with substance use. A lot of this around the COVID epidemic. So the rates were increasing before COVID, but then you have COVID, which makes people more susceptible to using substances because they're alone and isolated and, you know, maybe didn't have work, anything to do. There was also less contact tracing and disease intervention services that were happening during COVID for non-COVID issues. And so no one was following up and treating positives or finding their partners and treating them. So all of that made for this situation right now in Indian country and with American Indian and Alaska Native people that have, you know, an increase in congenital syphilis 800% over the previous year, just over the previous year. I think it's like 1,500% since 2016 increase, and that's huge. And it's avoidable, very easily treated. So along with there being a clear association with substance use, there are also specific vulnerable populations. The LGBTQ and Two-Spirit population are particularly vulnerable. Adolescents, you know, those aged 14 through like 24 are vulnerable. Pregnant people, especially with syphilis, are very vulnerable. And then racial and ethnic minority populations, American Indian, Alaska Native included, having actually the highest rates now of primary and secondary and latent syphilis, and also the highest rates of congenital syphilis. And there's also a high morbidity of congenital syphilis. There have been an increasing number of babies who die either during childbirth or shortly after because they have syphilis, something that could easily be screened for and treated for. So around the syndemic, and when I say syndemic, I mean STIs, so chlamydia, gonorrhea, syphilis, HIV, hepatitis C, and substance use disorder. Why it's so important to also be thinking about and addressing substance use disorder in this time is that young adults who used an illicit drug in the past year were 3 times more likely to get an STI. And the syphilis increases are particularly attached to methamphetamine and fentanyl and other opioids. So especially on like when using meth, you have an increased sex drive. And so you're going to be having more sex as well. And so the more times you have sex, the more potential for getting infection and spreading infection. Regarding hepatitis, it accounts for almost half of new cases, 4 in 10 in the United States. So substance use accounts for almost half of all of the new cases of hepatitis. And that's just like what is recorded and reported. I feel like probably it's a little bit higher since many people aren't going to document substance use. There's a little bit of hesitation probably there. So, you know, throughout the presentation, I'm going to be talking about what's needed then. What's needed is a holistic and integrated approach to address the syndemics, including syphilis, that we can provide the care and treatment needed at the places where patients seek care, and also where the patients aren't seeking care. And by that, I mean, access to care has to be completely thought of differently, I think, in this moment in time. Access to care doesn't necessarily mean how far away you are from a clinic. It means, like, are people coming into the clinic? Maybe some people cannot come into the clinic. Maybe they're providing child or elder care. Maybe they have substance use disorder and they just can't get into clinic. Maybe they're houseless, they don't have a car, multiple different reasons. And so we need to figure out how to bring the clinic to them in certain cases. So if you look at congenital syphilis, this is a report from the CDC. These are the reported cases and the rate of reported cases by state in the United States for last year. So you can all correct me if I'm wrong. My earbud fell out of my ear. You can all correct me if I'm wrong. I think I starred all of the states that have urban Indian health organization in them. So 1, 2, 3, 4, 5, 6, 7 out of the 15 top ranked states have an urban Indian health clinic in them. And so that's a really good reason to pay attention more, see what we can do more in the states that have the highest rates. Because in a lot of these places, we feel that Native people are driving a large part of the increases in rates, especially in South Dakota, especially in Montana. I just know that from working in those states, like pretty significantly over the past year. It's definitely the Native folks in that state that are driving the increase. So what is syphilis? Syphilis can be transmitted sexually, vertically, and horizontally. So when we talk about congenital syphilis, that's not an STD. That's transmitted mother to baby. And really, to address congenital syphilis, we need to do more with syphilis in women of childbearing age, and then also in prenatal care, which is a huge gap in a lot of our clinics. So making sure that prenatal care happens, or at least someone can access the needed tests, you know, when they become pregnant and throughout their pregnancy. It is curable. Syphilis is curable with penicillin. There are 4 stages, and primary, secondary, and early, which is non-primary and non-secondary, are treatable with 1 shot of bicillin, if there's access to bicillin. The unknown duration or late syphilis is treated with shots or regimens for a longer period of time, or three different shots a week apart. So you definitely want to try to screen early, screen a lot, so that you can catch syphilis in primary, secondary, and early, so that an individual only needs to have 1 shot. So when we look at primary and secondary syphilis throughout the United States, you can see where there are really high case rates, or even high case rates. In the urban centers, for sure, there's always going to be like high cases of anything when there's, more people around, access to care is probably a little bit harder. So Seattle, Portland, multiple places in California, Phoenix, New Mexico, Albuquerque in New Mexico. So all of those places, multiple urban places in Montana and South Dakota. So also usually when I'm sharing this, it's to folks working in a more rural reservation-based setting. So the other blues here also overlap a lot with reservation or tribal lands. And you can see that in a lot of the interior states. So these are the reported cases of primary and secondary syphilis by ethnicity and race from 2017 to 2021. And you can see this year, going to 2021, the highest rates were in American Indian and Alaska Native people, and then other ethnic or racial minorities like Black, African American, Native Hawaiian, and Pacific Islanders. But American Indian and Alaska Native have the highest rates. If you break it down by sex, you can see it that American Indian and Alaska Native people, the females particularly, have a higher rate than females in any of the other race or ethnicities. Males are always going to have like higher rates, but in the females, that disparity is more prominent in American Indian and Alaska Native people. And this is a problem because when more women of childbearing age acquire syphilis, they have more of a chance of having a baby potentially with congenital syphilis. And so this is what that looks like, right? From 2012, you can see in blue, the blue bars, the congenital syphilis cases, just going up and up and up. And what is that following? Well, it's following also the female 15 to 44-year-old folks who are having primary and secondary syphilis. So as more syphilis increases in females, so will congenital syphilis cases if you don't have good access to prenatal care, good screening and treatment rates, and a lot of different places that individual can access healthcare. This is the number of cases American Indian and Alaska Native people have. So that's the blue. And then the blue is the case rate. So American Indian and Alaska Native people are going to have a higher case rate. They have less people. So it's 102 cases versus, the Black African American 885 cases. But there's only 5 million total American Indian and Alaska Native people left in the United States, due to colonization and certain measures that were put in place by the American government. So although the rate is high, it is 102 cases. I don't care about that. I think, especially in Indian country, and in Native people who have historical and intergenerational trauma, that they are either, manifesting or keeping inside. Like one baby is huge in our communities and in our families. So if you look at the reported cases by year and race and ethnicity of the mother, you can also see that American Indian, Alaska Native, you can also see the case rate here and how much larger it is than those underneath it. It's double almost or more when you compare it to other races and ethnicities. Like these charts are, we have to stop when we see these rates and we see these numbers. This is a problem. It is an issue that so many Native people have syphilis. It is an issue that so many babies are born with congenital syphilis. It's an issue that everybody needs to take pause and address. Look at all of the energy that was given to mpox over the past year. There's not that same energy that's being given to syphilis currently, at least not in Indian country. And so like everybody needs to pause to look at this, to look at the practices that have worked and are being endorsed as best practices from various different entities and implement those practices. These disparities are too big to ignore. So coming down off of my soapbox, this is a chart regarding congenital syphilis of all of the missed opportunities among mothers delivering infants with congenital syphilis. And this is with data from 2017 to 2021, but I'm just going to look at 2021. So a large amount of people have no timely prenatal care and no timely syphilis testing. So they don't have access to care or available to them. The other big component is that there's just no adequate maternal treatment despite receipt of timely syphilis diagnosis. So people may be getting screened and they're positive, but they're not being diagnosed in an appropriate amount of time, if at all. I do think part of this is because it's hard to follow up with certain people who might not have a cell phone, that don't have a home of their own. They're either out there living houseless or they're couch surfing from one place to the next. So that is where this overlaps with a lot of other social determinants of health. And then less so for late identification of seroconversion during pregnancy, no timely syphilis testing, despite receiving prenatal care, and clinical evidence of congenital syphilis despite maternal treatment completion. So when there's congenital syphilis, even though the mom has been treated. So, really focusing on these top two areas are going to give a lot of result in curbing congenital syphilis. So increasing timely prenatal care and syphilis testing and maternal treatment in association with the screening. So focusing on those two areas would be a good path forward. So this is just a reminder, of this holistic nature, really this, indigenous way of understanding the syndemics and the increases in syphilis right now. There are so many factors that contribute to the rise in syphilis and congenital syphilis. And I think so often we westernize how we're talking about syphilis, and we don't go beyond the clinical diagnosis. We don't go beyond, well, what can we be doing apart from testing and treatment? Because those are really the things that are going to potentially affect this and so many other outcomes in the long term. So things like reproductive health and family planning, making it easier to access those things. And if like this access thing isn't working the way it is working, thinking of new and innovative ideas, like a hub and spoke model for prenatal care, not like referring a patient out and then like, no one following up with the prenatal care patients, increasing prenatal care generally, increasing screening and timely treatment, thinking about how drug use affects this and how to care for people with substance use disorder generally, also in syphilis, mental health, housing, partner services, education, and like so many other things. So there's a lot of different pinpoints where we can intervene, and it will have positive outcomes, not only with syphilis, but also with everything else attached to the syndemic as well. Can I get a time check really quick?
Yeah, it's 2:26 Eastern, so 21 minutes.
Okay. So another way to look at this, and if you're not a clinician, you can also think about this case and like what are other places that can be intervened in from a community health educator viewpoint, a public health nurse viewpoint, a program person viewpoint. So Tiffany is 17 years old and she presented to the emergency department in late October 22, reporting UTI symptoms. She was UTI positive. She also had a positive pregnancy test. They were at a facility where they were able to provide an ultrasound right there, and they got her at 14 weeks. So the UTI was treated, and then prenatal labs were drawn and sent, and she was referred to the prenatal clinic, which happened to be in that facility. So it wasn't like going outside the normal facility for treatment. The prenatal labs came back. The RPR was a 1 to 128, positive TPPA, and also a positive urine chlamydia test. Everything else was negative or unremarkable for the lab tests that were drawn. Multiple phone calls went out to Tiffany, and there was a public health nurse visit, and Tiffany presents to clinic in early December 2022. This is definitely 2 months later at this point. She had a rash, but she was no longer with her partner and she declined to name him. So at that early December visit, she was treated with bicillin 2.4 for secondary syphilis, and then azithromycin for chlamydia. The prenatal care and ultrasound was arranged, and at the day of treatment, when her titer was drawn, it returned at a 1 to 64. In late January then, after several more missed visits, Tiffany returned for an ultrasound and prenatal visit. In January, her RPR was back up at 1 to 128, and she was positive for chlamydia again. So in March, after extensive outreach efforts and missed appointments, the PHN locates Tiffany at a site that was associated with methamphetamine use. She had reunited with her partner, Marcus, who was never treated in the first place. This is where she originally got her syphilis and chlamydia diagnosis. So that same day, Tiffany and Marcus were able to receive field treatment of with penicillin, and then they were also pan-screened for other STDs and infections. So it was so important that when the public health nurse went out there to find Tiffany and Marcus, she was able to bring treatment with her and like not relying on them to come into clinic. That's not working. And then giving treatment where she was. Follow-up was arranged for prenatal care and syphilis staging for Marcus. Despite extensive outreach efforts, Tiffany was next seen in early April in labor and delivery. She was 36 weeks and 5 days. She had elevated blood pressure and apparent intoxication that came back positive for methamphetamine. She progressed rapidly in labor and delivered a 5-pound, 14-ounce baby with Apgar 7 and 6. The maternal RPR at delivery was 1 to 16. The baby's RPR was 1 to 32, with no other obvious findings consistent with congenital syphilis. But the baby had some respiratory issues and was transferred to an outside NICU. The baby, received full evaluation, including CSF analysis and treatment with penicillin for 10 days for possible congenital syphilis. Tiffany and her baby were lost to follow-up, and the family reported that they had left the area for sober living in a different state. So this case is so many of the congenital syphilis cases that are coming through clinics. You know, I hear versions of this case every week, maybe. And it's a hard thing. It's a hard thing to address, right? There's so many different times where that we could have potentially maybe done something different, or supplied Tiffany a phone. Maybe she didn't have one. Maybe that's why she wasn't able to be reached. But like, this clinic was like doing all they could. I mean, the public health nurse was going out and looking for them and everything. So, I don't know what in this case could be changed, unless, potentially asking further for Marcus's information early on. I don't know what else the clinic could do. But then it's like, but what does this look like from Tiffany's point of view? And then all of a sudden, I think that you can come up with like various different things that could have been done. Like, what if she doesn't have transportation? What if simply having, a cab ride or CHRs, or, I mean, I guess that doesn't work in urbans, but a cab ride or transportation arranged for Tiffany? What if no one ever asked her about her substance use disorder? Maybe she would be open to treatment, or at least some harm reduction services, which could open a pathway for screening and treatment and a safe place for Tiffany to go, and on and on and on. So I think, looking at this differently in a non-clinical sense, in a more holistic way, sort of opens up the potential for, what we could have done for Tiffany in a more comprehensive way, and not just focusing on that clinical diagnosis. So these are a few of the things that have come out, since October 22, when the CMO, the IHS CMO, came out with these recommendations. And what she came out with recommendations wise was that there should be annual syphilis testing for persons aged 13 to 64. These are recommendations that are happening before other national entities are even able to make these recommendations. So that's great, but what about like I bet you people don't do not recommendations all the time. So in order to increase that, wanting sites to adopt a STI, HIV, HCV testing bundle. And all of this is in the context of EMR reminder. So a reminder is going to pop up and say, you know, this person is due for syphilis testing, or this person is due for STI testing. And then doing the syphilis screenings with reflex to RPR, doing an HIV serology, screening for gonorrhea and chlamydia at 3 different sites, screening for hepatitis B and C, and a pregnancy test. And that's the important thing, a pregnancy test with every single STI screen. She also supported adoption of express testing. So on demand, no provider, no nurse lab visit for testing, walking in and getting tested, to make it easier for people to come in, not have to wait a long time, not have to like talk over and over and over again about, you know, things that make them very uncomfortable. And this doesn't necessarily include people with symptoms. Also screening outside of the hospital and clinic in the community, and going out and finding people out where they are. So I just have this, I have one clinic in mind, and like there are people with substance use disorder that hang out less than a block from the clinic, like a lot of them. And so, but they don't go out and test them, or, you know, beyond testing, develop relationships with them. And, you know, have harm reduction kits for them, or food for them, or clothing for them, or anything. So beginning to develop this relationship with people who aren't coming into the clinic. And then also utilization of I Want the Kit for self-testing. Currently, the IHS supported I Want the Kit is only available for chlamydia, gonorrhea, and HIV. By midsummer, it will add syphilis and syphilis to that list, potentially, and hopefully one day, including hepatitis C. And then also what was done in Tiffany's case, field treatment for syphilis by PHNs or other nurses with benzathine penicillin. And I'll go over these a little bit more. But first, like, I just want to also say that there's a syphilis penicillin shortage. It's the national treatment priorities for IHS are pregnant persons and HIV infected persons with syphilis, as well as infants with congenital syphilis, should receive priority for treatment with benzathine penicillin. And benzathine penicillin is the only recommended treatment for pregnant people infected or exposed to syphilis. So if we don't have benzathine penicillin for pregnant people, we have no other way for treatment that is recommended treatment. Other persons with early syphilis, primary, secondary, early latent, and sexual partners should be treated with penicillin if supplies are adequate to cover high-risk patients listed under priority number 1. Most sites don't have this now. They don't have enough treatment courses to get them through, you know, the patients that they currently have, or the projected future. And, you know, if you go into a lot of different ordering platforms, you'll see that benzathine penicillin is unavailable. If benzathine penicillin supplies are inadequate to cover patients listed as priority number 2, treatment for early syphilis with doxycycline, 100 milligrams for 14 days, and late syphilis or late latent syphilis of uncertain duration with doxycycline, 100 milligrams for 28 days. So, I mean, they're like, first of all, we need to be thinking about this if we have a local pharmacy, or even if we don't have like a in-house pharmacy, this shortage is gonna remain until the suppliers are able to make the necessary drugs to go into the bicillin. So, I mean, I've heard maybe that there won't be another stockpile of penicillin potentially until early fall, but maybe the folks from the CDC who are on this call can clarify. So we also have, if you want to like use this and go to the web page, we have what we call a syphilis crosswalk. So we have taken past recommendations from previous CDC STD directors, also academic literature, and what we know from Indian country, and compiled it into the syphilis crosswalk that goes through all of the different ways in which we can address syphilis, like currently in our systems. And then also, really exciting, we just got new information up on stopsyphilis.org. Don't copy this way to spell syphilis. Make sure you copy it with only one L. But if you go on here, we have congenital syphilis campaign materials, condoms, and then general campaign, syphilis campaign and condoms for like young people, LGBTQ folks, you know, everyone else, basically, elders. And so these are things like, you know, billboards you can put up in your community, rack cards, posters, those shark fins that you can put up inside of your clinic, and those are all free to order. Not the billboards, obviously we can't buy a billboard, but you can download this and then pay to have the billboard put up. This just happened in Montana. I think they had like 7 billboards up in the state. And if you have like funding, if you don't have funding for billboards, please reach out to me, and I should be able to cover funding for putting these billboards up. And then another thing that just keeps on coming up in the conversation is services for pregnant people who use drugs, or pregnancy and drug use, as it relates to syphilis and not. So we have plans of safe care. It's not like the national plans of safe care, which are really wholly focused on CPS. This is a more holistic way of looking at care for pregnant people who are using drugs. It provides the opportunity for both medicine and social and cultural and spiritual and other service providers to collaborate across disciplines, to wrap the pregnant person in a community, in a care community, and includes the family also in this process, and talks about, you know, how we can treat pregnant people who use drugs, and help them get to a place where they have a plan for their pregnancy. Also, the creation of services for people who use drugs, like harm reduction, having and setting up a harm reduction space or program in different facilities, clinics, whatever, a place where people can start coming and building relationship with people who are not judging them, and then thus opening up avenues of communication and care for the people who are using drugs, which does not happen in the regular clinic for the most part. I mean, largely folks are coming to clinic who are using drugs in the emergency department or the ER. Then also there's this amazing street medicine program out of Northern Navajo. It communicates with the public health department in New Mexico and Colorado. It does partner services for the people who are on the streets. It does rapid testing and draws for confirmation. They have penicillin on them so that if there is a rapid test positive, they're able to treat right there. They also have Vivitrol injections, oral naltrexone, and they hand out Narcan and harm reduction kits. They also work with the Northern Navajo Medical Clinic to help keep pregnant people in care. So a lot of the time, the actual clinic will call on the street medicine program that's led by a clinician, saying like, we really can't find this person, and or this person has syphilis, and it's the street medicine program that finds the person and is able to do that follow-up. On average, during a clinic, they will find 2 to 6 new cases of syphilis each time, because they're getting to a population that's not coming into the clinic and has a high rate of syphilis. And they also communicate with jails and the counties for follow-up. For instance, if, in the jail, like on departure, they had a positive syphilis, they will communicate with Northern Navajo Street Medicine Clinic for penicillin or for wound care or meds being delivered or and whatnot. And then lastly, I think there's an express STI testing QR code there, and it goes over everything that you need to think of to start up an express STI testing space in various different ways. Like there's no like one way to do express STI testing. It's, what works for you in your space and your population, and all of the different policies and protocols and posters and everything that you would need for starting up the express STI testing. And I'll follow up and I'll send all of the links in an email too. There is Ending the Syndemic Syphilis virtual training. It's July 27th at 9 a.m. Pacific, and it provides comprehensive information for everything syphilis. And that's it. Questions, comments?
Yes, thank you so much, Jessica. That was so informative. If anyone has any questions for Jessica, please feel free to unmute yourself, type your question in the chat, or you can send them anonymously directly to Jessica if you would like to stay anonymous, and she can read your question out to the rest of the audience. But I have a couple more minutes for questions.
Hi, this is Jess at South Dakota Urban Indian Health. Thank you so much for all of that information. It's extremely helpful. So I want to say that first and foremost. Second of all, I have a question, or maybe I'm looking for some guidance, but in South Dakota, we have 2 clinics, one in Pierre and one in Sioux Falls, and Pierre is definitely a more what you would consider rural than Sioux Falls, and that tends to be where the majority of our syphilis cases kind of stem from. And my question is, we are struggling right now as a UIH to fund the Bitsilin, to fund the vaccines for syphilis. Our state is very behind in getting on that syphilis is actually happening kind of train. And so my question is, do you have recommendations for maybe outside sources? I know we've partnered with NCUIH, and we're grateful for their support, but that's kind of right now where we're struggling. We have started a street outreach program in Sioux Falls, the OKA street outreach, to kind of reach out to some of our houseless population relatives within that community. But it's really the vaccine funding, just knowing that the majority of our people that we serve are uninsured or underinsured, and you know, each vaccine is $400 roughly a dose, and so I'm looking for maybe some suggestions that you have, and I'm happy to communicate if this isn't a big group question.
I think the idea of the bicillin cost is a really important one. So there's, just to clarify, there's no vaccine for syphilis, but there's a treatment course for syphilis.
Treatment, yeah. I apologize. That's
no,
what
it's
I meant.
okay. So yeah, and each one, if you're not accessing 340B prices, or McKesson prices, which are even higher, is going to be about $400. I think it's like 3 cents if you access it through 340B. So do you have a pharmacy in your urban Indian health centers?
We do not have a pharmacy within our urban Indian health centers. And also we have been advised against the 340B program as not being a good fit for our clinics because of just, I guess, reasonings that it's not cost effective for us at this time.
Okay. Well, I mean, if you don't have a pharmacy, it would take a lot to set up a pharmacy. But for sure, 340B for various different things is cost effective if you're talking about 3 cents to $400. But I think I can link you up with the state. I work with South Dakota a lot. I can, having a state contact or a local health district or jurisdiction contact, having that collaboration can be really beneficial. In some places, in some states, it's a little bit harder. So I acknowledge that for you. But potentially there is a local health jurisdiction that would be able to potentially link you up with someone else, like a local STD clinic that does have 340B pricing. So you could refer the person to the local clinic. And then, there's just there's other things that I could talk to you about in South Dakota. But there's the potential to work collaboratively with all the urban Indian health institutes, and maybe this would be beneficial to access the McKesson mail order pharmacy that IHS uses, and have most treatments mailed to their doors, save shots of penicillin, and have them come back potentially or go out to them for penicillin. So there's a lot of things I think that we can talk about.
Okay, thank you.
But I will say that collaboration between, tribal health, IHS, urban clinics, the state and the local health jurisdiction, and with like national partners. I know the CDC is really involved with the EpiAid that's going out to South Dakota. I think that having regular calls is like really is really important in addressing syphilis right now, and also the pandemics.
Other questions for Jessica?
I think just before I leave, and please feel free to reach out to me. I will put my email in the chat. Can't do two things at once. So I think just before signing off, I really do think this idea of holistic and coordinated care is really important when addressing these overlapping epidemics with syphilis and substance use disorder and hepatitis C and other STIs and HIV. And like, we have to think about an array of different things, the things that work best for our community, but also acknowledging that there should be, like, every door should be a right door, like where you can go in and receive screening and treatment. Like a person who's coming in and wants to get tested should not be told that they don't have any appointments until tomorrow or next week. Truthfully, like, emergency departments, no matter where they are, should be screening, because so many people don't have primary care providers who are the highest priority in the current outbreak. And so, like, establishing and coordinating with the emergency departments that you do work with, saying, like, there's this increase in syphilis, like, are you screening, and having that conversation is also really important. And then also this idea, and I've seen this in various places, there isn't any community facing information. The community might not know that there is an outbreak going on. They might not know the safer sex strategies to avoid syphilis. They might not know that they should come in and get tested whenever they might be exposed to syphilis. So getting more, community education and outreach materials out there is also really important. Thank you for listening to me.
Thank you so much, Jessica. That was so informative. Appreciate you sharing your knowledge with us. So just keeping an eye on our time, don't want to go over the hour too long. Just our final reminders as we close today's event. NCUIH has a couple more events coming up this summer. You can go to ncuih.org/events to learn more, but our final event for this series, Standing Together to Address Urban Indian STI Disparities, will take place on August 2nd, 2023 at 2 to 3 p.m. Eastern. So stay tuned for more details on that. Next slide, please, Rachel. And then one thing I wanted to make sure that we highlighted for UIOs is we're creating an STI questionnaire for UIOs to understand STI service capacities at UIOs and also barriers and needs. So if you'd like to earn a $250 gift card for UIO, please complete the questionnaire. It takes only about 15 minutes to complete and is more directed towards clinical knowledge. And so to learn more, you can scan the QR code or visit the link that is just posted in the chat. And we can also share all that info to you via email. And then lastly, so finally, we'd appreciate any feedback on today's event. So to complete our feedback survey, you can scan the QR code here or visit the link that Sophie just posted in the chat. We'll also share that via email after today's event and in addition to the today's slides and all of the other reminders. So if you have any questions about the event today, feel free to contact me at the email that Sophie posted there at mcurry@ncuih.org. And or if you have any questions for Jessica, I feel free to reach out to her as well. We'll volunteer for that. And then we have a wonderful rest of your day. Thank you, everyone.